progress in getting there. And one thing to look at here is that the Americas, I believe, would include North and South America. And you can see that more than 20% of the patients who are getting tested have VEGFR, and this is important because of the drugs that the patients can get. So again, drugs and surgery or drugs and radiation, the decision is made early, and it should be made in a multidisciplinary conference. Get the best people in the room, and it's not just the treating doctors, it's the diagnostic doctors too. Many times for stage 3 lung cancer, there's lots of questions that have to be answered, and it's faster if everyone gets in the room and you review it all together. You would not just the radiologist, but if you can get the nuclear medicine physician to come, buy him or her breakfast if you have to, bring the pathologist to look at the slides, and the interventional pulmonologist who can do the EBUS and the biopsies. For me, without those people in the room, it's just not the same. And for me to have these people in the room, they can schedule all the additional tests that are needed to get things going so we can talk about treatment. And of course, you always want the treating doctors in the room. And I know the surgeons are often the busiest doctors, so please be nice to them and schedule a time when they can actually come. It's just not the same without a surgeon in the conference. So the next thing I want to do is help us understand the literature that's being published. We're seeing lots of research studies being published that talk about stage 3, but sometimes they're not specific. Are we talking about clinical stage or pathological stage? When you look at the NCCN guidelines, the patient can have any stage of lung cancer, go to the operating room, and depending on what you find, positive margins, stage 2, stage 3, then there's a bunch of clinical trials, and I put the 3 most recent phase 3 randomized trials here for you to be aware of. The patients after surgery come out, and based on their pathological stage, are recommended. ADAURA is going to be osimertinib, IMpower is going to be atezolizumab, and PEARLS is going to be Keytruda. This is pathological stage, but it's not the same as what the patient had before they went in. And I say this because as radiation oncologists, we are obviously working with the clinical stage. So we're talking about clinical stage 3. This can include patients who were clinical stage 1, went to the operating room, and then had lymph node disease. For radiation oncologist stage 3, I'm talking about known stage 3 disease before any treatment is delivered. And I want to show this study in case you're not aware to describe why today it is drugs and surgery or drugs and radiation. And it's because after surgery, there really isn't a role for radiation anymore like there used to be. PORT stands for postoperative radiation. This is a phase 3 randomized trial completed in Europe, published just last year, that lets us know that routine radiation after surgery, just to be safe, does not seem to improve survival. The study was designed with a 3-year disease-free survival endpoint. The goal was to increase the disease-free from 30 to 40%, and the actual results, it only improved it 3 percentage points, from 44 to 47%. And if you look on the right, we wonder, well, who was in the study? You had patients with single N2 disease found at surgery. These are all pathological stage. You had some patients with multiple lymph nodes, discovered at surgery. And you even had people with extracapsular extension of the lymph nodes. The surgeries weren't all perfect. There were patients with positive margins, and a majority of the patients did get chemotherapy. And they were randomized to radiation or just observation. And you can see the overall survival curve, the difference on the right, shows that it actually favors no radiation. And people argue, well, maybe if they use IMRT, maybe if they had better planners. I disagree. I think this is a very good study. These were at clinical trial sites, and the DFS does not show enough of a signal to justify treating negative, lymph nodes where you don't know if there's any disease left or not. You just know that there was some in there. And why was this study negative? I always thought during my training that this didn't make any sense. If the cancer is in the lymph nodes, the cancer has already gone elsewhere. We need better drug therapy. This is not the end of the cancer just in this area. So again, the decision is made in the beginning. Drugs and surgery, bye-bye, or drugs and radiation. So let's focus just on the patients who are not going to the operating room. And for locally advanced lung cancer, the history begins back here. Chemotherapy was first discovered in the 1950s, and radiation therapy was starting to get better. But by the 70s, we still did not have CT scanning. So this is using X-ray fluoroscopy to identify the treatment fields. Nobody was crazy enough to add chemotherapy, so this is radiation without anything. And this dose-finding study, randomized, showed us that 60 gray was the best dose. Here we are, 40 years later, it's still the best dose. The cells are the cells. In the late 1980s, early 90s, the first randomized trial was published that showed a benefit to some chemotherapy. Some chemotherapy, not together, just some chemotherapy before radiation. Chemotherapy to clean up the invisible disease, radiation to treat the visible disease. Survival benefit. Later came concurrent versus sequential. And this is just one of the many randomized trials that showed there is a benefit to concurrent. We know it's more toxic, but even with that toxicity, people will live longer with concurrent. And this was the case for a while. We kept trying to improve the outcomes with concurrent chemoradiotherapy. First series of studies was the idea of giving chemotherapy before chemoradiotherapy. You can see no difference here. Then they decided, what if we gave chemotherapy after chemoradiotherapy? All of this time, all of these patients, all of this money, no benefit. And look at the toxicity. More chemotherapy is bad. More hospitalizations, more people dying from a fatal complication from the immunosuppression of more chemotherapy. So a decade or so went by, no progress. What did we do next? Well, let's increase the dose of radiation. And what happened? I think every radiation oncologist in the world now knows these results. More was worse. 74 gray was the losing arm. And this was an amazing study. I knew academic radiation oncologists who felt it was unethical to give 60 gray. They closed the study. They said they wouldn't randomize the patient. They gave everyone 74 gray. And even after the study was published, they said, well, I don't kill anybody with 74 gray. I tell you right now, I think that is crazy. 74 gray was shown in a phase 3 randomized trial to be more harmful. It killed people, and it should not be used outside of a clinical trial until new evidence shows that it can be delivered safely and actually have better outcomes than 60 gray. We know more is bad, and we shouldn't be giving it unless you have proof that it's actually better. Now it's 2015. What do we do? I'm an attending. I've been waiting through medical school and residency for things to get better. No hope. This study, by the way, also, if you read it carefully, they also did another randomization. They did chemoradiotherapy followed by cetuximab. Same thing. No benefit. So no hope. The room is dark. We don't know if we're ever going to get any better. And then finally, this study was released in 2017, and it moved the curve for our patients. So 713 patients randomized in this trial received chemoradiotherapy, 2-to-1 randomization, They either got placebo for 1 year or they got durvalumab for 1 year. In this study, the patients were only enrolled after they finished the chemoradiotherapy, after they recovered, and after they had restaging studies and had no progression and no metastases. Then they were randomized. So the clock starts there. And this is an unbelievable trial because the patients came and sat in a chair every 2 weeks and got nothing but placebo to give us level 1 evidence. And these are the data. Finally, we had a breakthrough that showed improvement in survival. And this is the 5-year update. And you can see a 10% difference in survival. So happy, change practice around the world. However, what's really unfortunate is there's still a lot of people who are not getting this drug. And of course, that's why AstraZeneca wants me to talk to you. But I don't care if AstraZeneca makes any money or not. What I care is about our patients living longer by getting the drugs that have good evidence that it helps them. Now, overall survival, of course, is what our patients and their families care about the most. But progression-free survival tells you about cure. When a patient has a measurable lung cancer that gets chemoradiation and you treat it, if it shrinks and stops growing and never grows again, and the patient never needs any more treatment again, that is also important. So I can tell my patients based on these data, if you start the durvalumab, there's a 1 in 3 chance you'll never need any more treatment again. To me, that means cure at 5 years. If you don't get the durvalumab, it's 1 in 5. This is a big deal of not needing more treatment because patients really want to just go back to their lives. I know you love your clinic, but the patients don't want to be in your clinic. They would rather be at home or at the beach or in the mountains, someplace else enjoying their life. So I quote these data all the time to my patients. If you get through chemoradiation and you start the durva, 1 in 3, we can cure you. And unfortunately, in my experience, my practice, that is about what it is. I have some survivors, but I don't have a lot. Now let's get into the scientific details of the efficacy of durvalumab. On the left side, if you take the PD-L1 and divide it by high versus low, you see that both are benefiting. But statistically, this might not tell you the whole story like it does on the right side of the curve. The top one says any PD-L1 positive, 1%, 2%, 10, 50. On the bottom right, no PD-L1, 0. And you can see there is a big question mark. Does durvalumab help these patients? If the patient has any sort of a toxicity from durvalumab and you have to stop it, you probably don't want to restart it again because the chance of the harm might be more than the benefit. But in all the other patients, it really appears that the benefit is better than any potential harms. Here is an analysis from the Pacific investigators in the 5-year update. You can see the top line, if you had EGFR or ALK, it doesn't appear that this drug is helping them. Whether they get placebo or durva, it's about the same. And the bottom line, if also the PD-L1 has no signal, there's actually a hint that maybe placebo does better, but statistically speaking, it doesn't appear to be a benefit. What do we do at UCLA and a lot of the other practices in the US? We talk to the patient. And the patients always want something more because we know how bad it is with chemoradiation stop. So we will give it, but if there's any toxicity, we usually stop immediately and just hope that they're the 1 in 5 who will never have a progression. We looked more at this situation with, excuse me here. We looked more at this situation with in the VA with the real world data to see if we could measure the association of the PD-L1 status. In the green line, these are the patients who got chemoradiation alone and no durvalumab because it was before 2017. And then you see the 3 cohorts in the durvalumab era, and they're getting the durvalumab, and you can see just like the other data, If your PD-L1 is less than 1%, it looks just like you never got Durva. But if you do have 1 to 49% and 50 or higher, there is a benefit. And I would say that, there's all these numbers, but most of the research right now is putting the PD-L1 into these three categories. It's either negative, less than 50, or greater than 50. And you'll see these in a lot of analyses. The other thing that we did with our VA population with 1,000 patients who got the durvalumab is we studied what happened with during the 1-year period that they got the durvalumab. So the x-axis on the curve is 365 days. So these patients finished chemoradiation, started durvalumab, and half of them didn't get to the end of the year. And here are the reasons. One of the biggest reasons is progression. We need better drugs. This is during the year. This isn't after durvalumab. There were some toxicities, of course, and treatment is stopped. And the good news is that the serious complication rate actually is not that high. And I'll show you some other real world data in just a minute. The median duration in the VA was about 7 months. And in the VA, the 12-month completion rate was only 30%. AstraZeneca funded this global study to get another real-world evidence evaluation. Our study in the VA was retrospective. This was prospective and carefully coded to capture true toxicities. And they were very interested to find out, why does the patients discontinue durvalumab? And you can see here that disease progression was also a major component, 26%. On the right side, toxicities in the real world, you can see moderate and severe pneumonitis, less than 10%. And the good news, knock on wood, the fatal events was much less than 1%. For many European countries and other countries around the world, this gave them the signal to go to their national health agencies and get the approval for this drug for their patients. So we love durvalumab. We want the results from the Pacific trial. So how do we optimize the patients for the Pacific journey? The first thing I always do with my patients is I prepare them. This is not just radiation and then go see what happens to radiation oncologists. We are a team, and we're talking about a 16-month commitment. We're talking about several months of radiation, several months to recover, and then 1 more full year of durvalumab. The second thing, pay very close attention, because if I hurt the patient with the radiation and they never get the durvalumab, they're going to be that 1 in 5 patient. And the third thing is during the treatment, if the patient has esophagitis and they're not eating, they're not swallowing, we have to manage that like an esophageal cancer patient. We have to have them stay well nourished so that they will be fit enough to get their durvalumab. So let's talk a little bit about radiation planning technique. So if you forget to get the IV contrast or you don't have it, I'm going to convince you that you should. Here is a patient with a non-contrasted CT SIM. Mediastinal windows on the left, lung windows on the right. Where does the tumor start? Where does it end? Where are you going to contour? Look at what happens when you turn on the image with contrast. Ta-da! You will contour a lot less, and this will make it less, this will make your treatment safer to deliver, again, so the patient doesn't get hurt. I recommend you figure out how to make sure there's always contrast at the time of safety simulation in your department. Next, the CTV margins. The global standard of care has been to add 7 millimeters to the GTV. There is good data that says you can make it 0, just like with SBRT. You still want to put a PTV around it, but you can consider taking the CTV to 0, and I'll show you some data in a second. Next, we know that IMRT takes the high doses and puts it only on the tumor. And I believe it's the high doses that injure our patients, and the high doses should be as closely wrapped around the tumor as possible. This is a study from Salma Jabbour and her group in New Jersey. And they showed that at the institution, the doctors used all sorts of different margins. When you add the CTV and the PTV, some of them had very little, some of them used a lot. And when they divided by large margin and smaller margin, look at this. No difference in tumor control. And what's interesting is that the smaller margin, which I'm recommending, is usually used for the bigger tumors because you cannot meet your V20. Bigger tumors, smaller margins, and they did just the same. Going back to the 1970 studies, if 60 gray can eradicate the cancer, 60 gray will eradicate the cancer. We don't have to go higher, treating bigger areas. And of course, if your margins are smaller, look at the difference in the pneumonitis and esophagitis. Next, they are now studying in the US the idea of giving SBRT to the primary tumor before giving the 30 treatments of chemoradiation. Will this make it better? We don't know. Do I do it? Sometimes. The phase 3 study will help us understand how important it is and whether it will reduce toxicity and improve outcomes. We know that SBRT has a better local control rate than regular radiation, but we really don't have good data about SBRT versus 60 gray chemo-RT. The data suggests that chemo-RT is inferior, so I'm hoping that the SBRT will show a better outcome. And if you will excuse me, my CT simulation is calling me to take care of a patient. I'll be back in 2 minutes. Hey guys.
Hi.
Do you see it?
Can't we see it?
Yeah, it got bigger. All right. Looks good.
Dr. Mokanaki, when would you like her to start? She said something about a PET scan.
It's got to be after the PET scan. Yep.
Okay, so right now her PET scan, she said, is on the 12th.
Thank you for that. Okay, back to where we were. So the SBRT question remains for stage 3 lung cancer. All right. The next advice I have for meticulous radiation therapy is good communication with your team. The image alignment, I would say, might be more important than the quality of the treatment plan. The team needs to know, how often do you need to get a picture? Every day? Every week? Some other schedule? For my lung cancer patients, I get an image every single day. Next, are you going to use MV, KV, cone beam CT, or both? With MV, you can see the carina. That's great. With KV, you can see the spine and the ribs. With cone beam, you can see it all. With cone beam, you can also sometimes find if there's been a pleural effusion or some sort of atelectasis, shifting of the tumor. In my practice, I get cone beam every single day, especially because I'm not using any CTV margin. I have a 5 millimeter, sometimes 7 millimeter PTV margin, and I want to be sure that the alignment is good. Then, communication. If you're going to do one of these images, what do you want to align to? Are you going to match to the carina or the spine? Or cone beam to the tumor? In my practice, we write all of this down so the therapists on the machine know they don't have any questions about what to align to. And this helps increase the precision and the accuracy of the treatment. Now, I want to talk for 1 minute about the patient who can't get any drug therapy. These are frail. Medical oncology says, nope, no drugs. Patient's too sick. We have all this new technology. We think we can deliver treatment faster. We love SBRT, but these tumors are very big, stage 3. So we can't give SBRT, but we wonder, maybe we can give 4 gray times 15. More dose, shorter time, can't give drugs, so maybe it'll help them. Look at what happened in this phase 3 randomized trial. I want to start with the bottom left figure, C. We know that 60 gray in 15 fractions is more dose. And yes, the local control was better. It is more dose, it is more efficacious. But what happened to the survival, the top left, graph A? The patients who got shorter hypofractionated treatment, IGRT stands for image-guided radiation, died faster. And people will say, why did this happen? So you look at figure B. Was it because of disease imbalance in the nodal and distant disease? Not necessarily. What about metastasis? Well, higher dose of the primary actually reduced metastasis. That's a good thing. So why did the patients die faster? If you look at this study published 2 years ago, the first thing that me and probably a lot of people look for is grade 3 difference. Guess what? There's no difference in grade 3 between these two. There's a difference in grade 2 complications. It's a reminder when a patient is so frail that medical oncology says no chemotherapy, we have to be very careful, and even grade 2 can kill the patient. So I no longer give hypofractionation to a patient who has a large tumor who cannot get any chemotherapy. All right, so where are we going in the future with all of this? Well, this is where we started. Radiation alone, the history I find back in the 1940s, and then 50 years later, they gave chemotherapy before radiation. Then they gave it together. Then they added immunotherapy to get to the best survival we've ever had. But we continue to have this problem, as I mentioned earlier. In the US data sets, 17% of patients with stage 3A, not 3B, 3A, don't get surgery or radiation. They just get chemotherapy. So there's something about the belief that you can cure stage 3. I think there's a lot of non-believers, and this is what gives me the passion to talk about this. Next, this is non-scientific data. One of the most famous academic medical centers in the US, where a very famous medical oncologist told me at a conference last month that they looked at their data and 1/3 of the patients who got chemo-RT didn't get durva. I don't know what's going on. Maybe the radiation oncologist is forgetting to emphasize the importance, or maybe the radiation is using such big fields of radiation that the patient is so sick, they don't want to come to the hospital ever again. So all of these things matter, and all of these things affect survival. So what's going to happen in the future moving forward? Well, very few people have read this study. This is an amazing study. This is the Pacific regimen. Durva alone is the losing curve in this figure. AstraZeneca did this phase 2 trial, almost 200 patients, randomized between dual therapy with monalizumab or oleclumab. And this combination is now being studied in the Pacific 9 phase 3 randomized trial. Here are the drugs and radiation trial that are ongoing. And it's a reminder why we have to keep paying attention to all the details of the drug therapy. More dose is not going to help. If we want to help our patients, we have to become experts with understanding these drugs. So Pacific 2 has been finished for a while. We may see the results this year at a meeting. And what they did is they combined durvalumab during the chemo-RT phase in addition to afterwards. The next study, Key-Link, look at all of these different drugs that they're throwing and combining with the chemo-RT and after the chemo-RT. Key Vibe, another Merck study, again, excellent study design. user-specific as the control arm, combining a different drug combination. Checkmate, Bristol Myers Squibb. They are now also combining their checkpoint inhibitors, PD-1 inhibitors, not PD-L1. Nivolumab is a PD-1 inhibitor. And ipilimumab, CTLA-4 inhibitor. Pacific 9, as I just showed you, this is a 1,000 patient study looking at different drug combinations. And then for the EGFR positive patients, we're looking at chemoradiotherapy followed by Tagrisso or osimertinib, another AstraZeneca drug. It's possible that all of these studies will be published in the next 3 to 5 years. And then finally, we're not giving up on what I call the local control problem. The local control problem is that we still see a lot of progression. This is why we like surgery over chemo-RT whenever it's safe. And we know that there's a lot of DNA repair problems. Then fortunately, this is being tested in a collaboration in the UK, randomizing patients with this platform study design, trying all sorts of different drug combinations to see how we can improve the local control rate. For those of you who are very interested, I encourage you to read more about this Concord phase 1 platform study. And this is the picture with my good friend. Last time we were in Merida, and I hope to be down in Mexico to be with you all in person in the near future. Thank you very much.
Muchas gracias, doctor Drew. Excelente, excelente ponencia. Creo que ha reflejado todo el camino que actualmente está teniendo el cáncer localmente avanzado. Y bueno, pues quedamos abiertos a las preguntas, si hay preguntas en el chat. Por lo pronto yo voy a hacer una pregunta al doctor, que sería, ¿qué impacto tiene el iniciar durvalumab dentro de 42 días del final de la radioterapia, ya que en el estudio Pacific solo pudo lograrse en el 35% de los pacientes?
The Pacific trial actually didn't do a good job of studying what happened during chemoradiation. They are still trying to find the treatment plans to evaluate it. There's been some analyses presented in abstract and never published because the quality of the data is so poor. So I think that a real-world study would be nice, but even the Pacific R real-world study did not have a lot of information about this. At the end of the day, it's sad but true. The drug companies are more interested in the drugs rather than the radiation, except for these studies here that are actually looking, here, let's go back. These studies here that are looking at the combination of their drugs with the radiation. I'll screen share again. And in these studies, I've been reassured by the sponsors that they are collecting data on the radiation therapy treatment planning to help understand why some of the patients might not get it. So for example, look at Keylink 012. I have this study open at UCLA. If the patient gets hurt during this chemo-RT and Pembro and doesn't get to the drug, well, the drug company is wasting their time studying these drugs. So we'll have better data in the future with these studies about what happens during the chemo-RT phase.
Sí, hay una pregunta, ¿verdad? Sobre, nos piden, doctor Drew, que si puede hablar un poco más sobre dejar el CTB en 0. Si bien la literatura parece encaminarse a eso, creo que a todos nos preocupa una recurrencia en campo marginal. ¿Qué comentarios adicionales podría hacer con respecto a esta postura?
It is a real concern to have, and my recommendation is to track the data. At the NRG Cooperative Studies Program, we are surveying the country to find out how often people are doing this. And I do believe we should be carefully confirming that it is appropriate. The challenge is that the majority of the relapses are outside of the field. It is very rare to have marginal only progression in stage 3 lung cancer.
Ok. Doctor Drew, ¿considera que en un futuro sea posible disminuir el volumen a radiar para disminuir toxicidad con el uso de los tratamientos de radioinmunoterapia?
I really hope so. I know that in prostate cancer, they're starting to study this, where they're giving PSMA targeted drugs and radio-labeled drugs directly into the prostate before the radiation external beam is delivered. Unfortunately, there aren't a lot of drugs combined with radioligands at this time. There are a couple out there. In fact, AstraZeneca partnered with another company to create a radio-labeled drug. However, it still has not been tested, and we still don't know how well it's going to work.
Perfecto. Perfecto. Doctor Drew, ¿recomendaría una tecnología mínima para hacer de esto del CTB en cero, como por ejemplo únicamente IGRT, BIMAT? ¿En Estados Unidos se realiza esto fuera de ensayos clínicos?
Yes, it is being done outside of clinical trials. I know of at least several centers in California, including Stanford and UCLA, where we do 0 CTV. I don't think it's the treatment plan technology that matters. If the plan shows the dose is going to the target, that's great. I think the true challenge is the daily image guidance. So if you do not have cone beam CT, you probably want to do a bigger margin, but that's not the CTV margin. That's the PTV margin. If you have poor image guidance, you really don't know where any of your tumor is on any day during breathing. So the PTV should be bigger, but you can still stick to a 0 CTV. And it's not a lot of data, but we do have a lot of data that shows that people get hurt with large field radiation.
Ok. Durante años, doctor, la radiación se ha ampliado con el fin de lograr el control local. El combinarlo con inmunoterapia tiene como fin también el tener un control sistémico. ¿Cuál es su opinión con respecto a la afectación de la radiación en el microambiente inmunitario del tumor?
I think that there's a lot of hope that these drugs combined with the radiation and the tumor microenvironment is working better to eradicate the local tumor, but I'm not sure that's the case. There's at least one report that was presented at ASTRO last October. It's going to be published soon. It was just a retrospective study of patients who either got chemoradiation before Pacific was published and chemoradiation plus Durva. And they asked one very simple but important question. Was there a difference in local control? We know the distant control is better. We know the survival is better. Was there a difference in local control? The answer was no. The answer was it helped with the microscopic disease. And the scientists that I know think maybe because the radiation is actually harming the immune system inside the tumor. And so the PACIFIC-2 trial, which is concurrent Durva with chemo RT, we're very worried about it. Jeff Bradley is the PI. Jeff Bradley was the PI of the 0617 trial. And he told me he was very worried that it was going to be inferior. But the study did get through all of the data monitoring reviews. They continued, they finished all the patients. The toxicity wasn't too, because if the toxicity is too high, they would have stopped. And if the local failure was worse, they would have stopped. So we're going to have to wait until that study is reported to see. But the problem with the Pacific 2 trial, and this is going to be the big talk next year, or maybe later this year, is the Pacific 2 trial, the control arm was only chemo-RT. There was no durva given after chemo-RT. I think that's the next big phase 3 trial that's going to be presented. And, you know, radiation oncologists love to debate things, and that's going to be the one thing that they're going to debate. And Jeff Bradley knows a lot of people are going to be debating why they only did chemoradiation for the control arm. But my opinion right now, based on one abstract at Astro, is that it's very likely that it cannot improve local control, which is why I put the slide with the Concords trial, because we need to keep doing more investigational drugs during the radiation. And then you saw Merck and Bristol Myers is also doing studies combining the drugs with the radiation so we can address this local control problem.
Doctor, ¿qué opina sobre el uso de biomarcadores predictivos? ¿Ustedes los utilizan como la radiómica, el DNA circulante, para identificar subgrupos especiales de manejo?
Not in clinical practice just yet. Only the PD-L1. And then again, that's because of its thinking about the package of drugs and surgery or drugs and radiation. So if a patient has a large tumor, so this is a Dr. Corona issue, and we think, oh, well, with drugs, we're going to shrink it and go to surgery. If the patient's PD-L1 0, it's very unlikely that immunotherapy is going to shrink that tumor. So then we say, come on, let's be serious. We should probably go down the radiation route. But other than that, the other markers, they're still investigational. And what would you use them for? To increase or decrease dose? Unfortunately, you still need trials to show that that's a good thing. Maybe there are some that are doing it. I can't. I am training residents. I have to teach people how to follow the evidence. And if I become experimental in an academic university, then they will become experimental wherever they go.
Exacto. Muy bien, doctor. Pues si no hay más preguntas, agradecemos al doctor Mogaki su excelente presentación y toda la enseñanza que nos ha brindado esta noche. Nos gustaría, doctor, que diera sus conclusiones y el mensaje para llevar a casa.
So I have a sincere passion for Latin America. I know the Varian leadership that takes care of the Latin America territories, and I have been working with them for a long time to try to consult them and advise them how they can help improve technology. I want you to be aware that if you have good ideas, you should contact the people at Varian. They have money. They have more money than ever before because now they are part of Siemens, which is a much bigger company. That is a German company, much bigger than Varian. And they care about the quality of radiation therapy in Latin America. So I would recommend, I talked about this in Merida, is that if you reach out to them, they may be willing to fund some of your projects to improve the quality of radiation therapy in your area.
Pues muchas gracias, doctor Mogaki, y es un placer nuevamente tenerlo con nosotros. Esperemos que pronto podamos contar con su presencia en otro evento. Gracias. Buenas noches.
Thank you. It was a pleasure.
Buenas noches a todos. Perdón.
Sí, el doctor Lozano va a dar algunos anuncios sobre la estadística.
Buenas noches a todos. Antes de pasar a eso, quiero de nuevo darle las gracias a AstraZeneca y en particular a Lisbeth Farabeo por su disponibilidad y apoyo para poder realizar esta sesión académica. De forma preliminar, les puedo decir que tuvimos 285 inscritos, 210 personas conectadas y 203 personas contestaron la encuesta. Sabemos que el 90% de la gente que asistió a esta sesión son médicos radiooncólogos, el 48% del centro del país, el 20% de occidente y el 16% del noreste. Por esto, muchas gracias. Queridos compañeros, mañana vamos a comenzar con un innovador proyecto en radiooncología por parte de la sociedad. Como especialistas en radiooncología, compartimos todos el mismo descontento. Las demás especialidades no nos conocen lo suficiente. Esta falta de reconocimiento no solamente afecta la atención de los pacientes al no ser referidos de forma temprana o adecuadamente, sino que también dificulta el seguimiento de nuestros tratamientos. Creemos que la mejor forma de romper este paradigma es realizando sesiones en conjunto con otras especialidades. Mañana vamos a dar inicio al primer simposio multidisciplinario en colaboración con la Federación Mexicana de Ginecología, aprovechando que este mes se celebra el cáncer cervicuterino y se celebra la concientización del cáncer cervicuterino. Estamos entusiasmados porque este evento cuenta con el aval académico de 2 consejos diferentes y tenemos ya 991 asistentes confirmados. Sin embargo, ahorita en este momento nos encontramos debatiendo qué estrategias tomar, si aumentar la licencia de Zoom, contratar otra plataforma, limitar la asistencia a 1000 personas. Tenemos el tiempo encima, entonces, pero bueno, no se preocupen. Este es solamente el primero de muchos simposios que tenemos planeados. Estamos trabajando arduamente para presentar otro simposio en abril junto con la Sociedad Mexicana de Neumología, conmemorando el cáncer de pulmón. Esperamos concretar más proyectos con otras sociedades médicas pronto y se los iremos informando conforme se vayan desarrollando estos proyectos. Esos serían los anuncios. Muy buenas noches a todos. Gracias.